Ramadan fasting for patients with painful diabetic neuropathy. These are my disclosures. I have received lecture consultation fees from Novo Nordisk, Lilly, Sanofi, and P&G. I have an investigator-initiated grants from Procter & Gamble and Pfizer, and I have no stock. So where do we start? Well, we start with a request from Mohammed for me to speak on Ramadan and painful diabetic neuropathy. And I thought, well, this is a simple task. I will just go. I personally haven't seen a worsening of diabetic neuropathy or painful diabetic neuropathy during Ramadan in my patients, but perhaps there were case series or reports out there in the literature. So I did a literature search. What did the literature search show? Well, actually, it returned 3 papers. And I thought, well, that's reasonable. But actually, if you read the papers, all 3 papers are from me and my group, but they are nothing to do with Ramadan and painful diabetic neuropathy, even though the search was Ramadan, painful diabetic neuropathy. In fact, the only reason that these papers have come up is because one of my colleagues, Marwan Ramadan, is a co-author on all 3 papers. So if you want to look at the evidence-based link between Ramadan, painful diabetic neuropathy, there is none. So then I went back to basics. I thought, so what changes during Ramadan, right? And how might this impact on diabetic peripheral neuropathy and diabetic painful neuropathy? And so if you actually look at what happens during fasting, what you will find is that there are metabolic changes which occur whether you're diabetic or not diabetic. We know there are changes in glucose and lipid metabolism. There are also changes in terms of cell survival. And these changes are really quite far-reaching and at the cellular and molecular level, multiple. And if you translate that into the impact it might have on tissues, then we know that fasting per se alters fatty metabolism, insulin sensitivity, ketone body production. But what happens in relation to nerve fibers or neuropathy? Well, in models, animal models actually predominantly, we know that there is an increase in parasympathetic tone, which may be beneficial in diabetic neuropathy. And there is also a potential for increased synaptic plasticity, enhanced cognition, enhanced neurogenesis, reduced inflammation. So there is a theoretical link that fasting could have an impact on nerves. And if we look at the pathogenesis of diabetic neuropathy, we know that actually high glucose and indeed altered lipid profile has a major impact in terms of the development and progression of diabetic neuropathy through inflammatory signaling. So we have a theoretical link that might suggest that if we fast and we alter these abnormalities, it might have a beneficial effect on diabetic neuropathy. And indeed, if we look at the risk factors for diabetic peripheral neuropathy, we know that alongside blood pressure, HbA1c, BMI, triglycerides, and total cholesterol are indeed important risk factors for the development and progression of diabetic neuropathy. And one might therefore logically argue that if you are changing any of these parameters, it might have an impact on diabetic neuropathy. And if we look at the other aspect, which is actually what Mohammed asked me to talk about, which is painful diabetic neuropathy, we know that actually in the Middle East, from a number of studies that we've performed recently in Qatar, that the prevalence of painful diabetic neuropathy is really much higher in this region compared to the USA or Europe. So it's around 34%. And we also know that Qatari Arabs, and particularly Arabs, have a higher prevalence of painful diabetic neuropathy, up to 44%, compared to the established numbers which actually are found in the USA and UK, which is around 22%. And we also know from the studies that we've done that actually probably not HbA1c, blood pressure, smoking, all the usual risk factors of diabetic neuropathy don't really play a role in painful diabetic neuropathy, but obesity is a major driver. So where am I going with all this? Well, we know, and this is a recent meta-analysis, that Ramadan fasting in people with type 2 diabetes has an impact on these risk factors. So for example, fasting plasma glucose, admittedly a very small amount, but does go down by 15 milligrams per deciliter. Similarly, HbA1c during Ramadan fasting improves by 2.27%. Total cholesterol goes down by 12.88. All the risk factors that we know are driving diabetic neuropathy are actually improving during Ramadan. And triglycerides are also improving, although very small amount. HDL actually gets worse, but weight, relevance in terms of painful diabetic neuropathy, relevance in terms of diabetic neuropathy also improves during fasting. So therefore, one might think that this would have a positive impact on diabetic neuropathy and diabetic painful neuropathy. However, what's the evidence that it actually does have an impact? Well, again, I did a search, zero. So Ramadan fasting and diabetic neuropathy produces one paper. And that paper actually, the reason why neuropathy comes into it is not because they tested or assessed the effect of Ramadan fasting on neuropathy, simply because neuropathy was part of the preamble to, and they were talking about there's more prevalence of neuropathy in people with diabetes in developing countries. And so we're back to a lack of evidence. So then I was really stuck and I was thinking, you know, what else could go wrong or change in Ramadan that might have an impact on diabetic neuropathy or painful diabetic neuropathy? So, time in range. This is the new big thing where we are monitoring glucose continuously. And actually, we know that there is an impact on peripheral nerve function in type 2 diabetes. So this is a very large Chinese study which looked at 740 patients with diabetes, type 2 diabetes, age 60, HbA1c of 8.6%. And what they showed was that actually, in terms of patients who are in range, that is, you know, less than 53%, 54 to 76% of the time, greater than 77% of the time, roughly a third each are in these different times in range. So low time in range clearly tells you that there's much more variability in the blood sugar, whereas high time in range is clearly very well controlled. And so is there a link between that and diabetic neuropathy? Appears to be that if you have a higher time in range, then actually you have higher composite nerve conduction. And similarly, actually, if you have a higher time in range, you have a higher composite amplitude. So the suggestion here is that if you have more time in range, you are less likely to have diabetic neuropathy, or you are better nerve function. Similarly, for autonomic neuropathy, this is actually in type 2 diabetes again, 90 patients, age 47, HbA1c 9.3%, separated into those with and without cardiac autonomic neuropathy, based on the Valsalva ratio, EI 30-15 orthostatic hypertension test. And actually, what they do show there is that whilst HbA1c doesn't really have an impact, coefficient of variations may, which is the mean amplitude of glucose, could be playing a role in the development or the presence of cardiac autonomic neuropathy. And indeed, very old data from our group in Manchester with Andrew Bolton and Sami Yubo as the first author in Diabetic Medicine, now published almost 20 years ago, we did show that there is a relationship between blood glucose excursion and painful diabetic neuropathy. This is a pilot study, 20 patients with type 1 diabetes, 10 had painful neuropathy, 10 did not have painful neuropathy. And in essence, that study was able to show that actually people with painful diabetic neuropathy have a higher glucose level, They also have a higher M value and greater glycemic excursions, although the MAGE value actually did not differ significantly. But so what you see here is a typical profile of a patient with painless neuropathy, pretty flat, whereas the patient with painful diabetic neuropathy, you can see, had really quite wide changes in their blood glucose level. And so what happens in diabetes, type 1 diabetes in Ramadan? Well, actually, in terms of glucose excursions, this is in type 1 diabetes, 14 patients, HbA1c of 8.6%, not very much. So if you take patients during Ramadan and outside Ramadan, really glucose excursions don't really differ, apart from, you can see this is the non-Ramadan phase where clearly they eat and so the glucose level goes up. So, and of course here, Ramadan, you get this rise at iftar. But overall, no significant difference in multiple measures of glucose variability in type 1 diabetes. In type 2 diabetes, this is a study published with 56 patients. What you see is this is actually different groups of patients. So the healthy controls, you can see very, very normal glucose levels, whereas people with diabetes with different types of therapies, those on metformin, those on additional like drugs like sulfonylureas or insulin, you can see they have some variability through when they're not fasting, but particularly during fasting, you can see that they start with a relatively high level, it drops during fasting, and then it of course rises at iftar. And that's what's expected. And there are some differences, particularly those on insulin. And actually there is a study, again, this is a more recent study, 33 patients with type 2 diabetes, HbA1c very well controlled, 6.7%. What they did is they looked at the start of Ramadan, at the end of Ramadan, in terms of CGM. And what they showed actually is very little, in that at the start of Ramadan, this is pre-Ramadan, non-fasting, going into the first 2 days of fasting, early Ramadan, initially there was a slight increase in glucose, particularly in those people on sulfonylureas. But if you looked at the glucose variability, that is time in range, time in hyper, time in hypo, no difference. And actually at the end of Ramadan, absolutely no differences. And so is there an impact of Ramadan, time in range, and on diabetic painful neuropathy? Again, no evidence, no studies out there. So the conclusion really of my literature search and what I think is physiologically relevant or clinically relevant is really that absence of evidence is not evidence of absence. And Carl Sagan said this. So we are really left with, I can't draw any definitive conclusions because we have no evidence. And so what I would say is that going forward, we need studies to assess the effect of change in risk factors during Ramadan on diabetic neuropathy, because we know those risk factors improve, but we need to be doing a before and after DPN study. Similarly, we need to look at the effect of change in glucose variability during Ramadan in relation to objectively measured or, measures of painful diabetic neuropathy, not just rely on the patients reporting this. Thank you.